Now in the second session devoted to youth mental health, which will be chaired by Erin Davis, the Vice President of Kooth for Government Relations. So, Erin, over to you.
Thank you, and good morning. I'm Erin Davis, as was introduced, Vice President of Government Relations for Kooth, and it's an honor to be here amongst all of the great panelists and speakers that we've had this morning, so thank you for your time and attention. We're going to shift gears a little bit for this session and discuss how collaboration between public and private sectors has emerged as a vital strategy for effecting positive change as we face and address this growing issue of youth mental health in particular. And so we have a great panel. I'm not going to spend more time talking, but I would like just a brief introduction from all of our panelists, and then we'll get into some questions.
I guess that means I go first. My name is Norman Lamb. I'm from the UK. I was a Member of Parliament for 18 years and Minister responsible for mental health between 2012 and 2015. Our family has experienced mental ill health, particularly in respect of our oldest son, obsessive compulsive disorder. We were failed by the system in the UK when we were in our moment of crisis. But my work, both as a Member of Parliament and as a Minister, demonstrated to me just how broken the current system is for supporting children and young people. And I think that from all of the work that I've done, both in the UK and internationally, the experience in the UK is matched by most developed countries. We have a heavily rationed treatment system which fails to meet the needs of families routinely. And I can't emphasize enough, therefore, the imperative for change. Monica was right. We've got to grasp this moment. It feels like a burning platform. The pursuit of happiness is underrated, it feels to me. And actually, we've got a crisis of happiness in our communities and amongst our young people. And so, both in terms of the pursuit of happiness and for economic well-being, it is vital that we reform our systems. And to do that, we have to do it in collaboration. We have to unleash innovation, and that means partnerships between state and private sector. I love what they're doing in California. I love the link up with Kooth. I also would just say finally that it's both a collaboration between state and private sector, but it's also collaborations with communities. Remember that proverb, it takes a village to raise a child. And I think we've got to unleash the power of communities. I was hearing about schemes in Philadelphia where children were just given the opportunity to play in circumstances that they don't normally have because of how dangerous their communities are. And we have to be able to unleash that power through working with community organizations, doing brilliant work within their own communities, supporting children and young people.
Thank you so much. Dr. Berke?
Is this on? Good. Hi, I'm Ethan Berke. I'm the Chief Public Health Officer of United Health Group and Optum. I'm a family physician and an epidemiologist. I've practiced for about 30 years and have been at United Health Group for almost 7. UHG is the largest civilian health provider in the world, and we're actually the largest behavioral health provider in the United States. We have about 400,000 employees worldwide. We touch about over 150 million lives, either through direct care delivery or through health benefits or health services. So this is an issue that we address every day when we partner with federal governments, when we partner with veteran organizations and Department of Defense or private organizations. I think you said something that was really striking, and as a family physician where I subscribe to the biopsychosocial model, I think we've lost the realization that there's not behavioral health and not medical health, there's just health, and there's just life, and when we start to parse things out, we mess it up. So I think it's important as we think about how to revolutionize and rationalize behavioral health delivery, we need to do it in the context of all the other components of somebody's life. And I think as we see people as an individual or a family or as a community at Optum or United Health Group, more and more we're thinking about how we integrate services that used to be in separate silos, and how do we really start to integrate, bring those services together and think much more holistically around healthcare. The other thing that I've heard a number of times, I'm looking around the room here, is anyone here actually Gen Z? No. So we're missing one really key voice in the room. And as a father of two Gen Zers, one who was involved in a lot of behavioral health work, she would say, without us at the table, the millennials will get it wrong. I'm off the hook. I'm a Gen X, so I'm a lost cause. But as we think about and design, and we want to hear the voice, and we all talk about that, they need to be at the table, because they're our best test audience and our best reflector of what they really think is wrong. And I love the happiness comment that you made too, because I think sometimes we over-medicalize behavioral health.
Totally right.
And there's a lot of people who don't need the full-on services, but doesn't mean that they don't have behavioral health. And I think there's an opportunity to rethink the system in that holistic way.
Yeah, thank
Hey,
you.
so good morning. Rushil, Desai. I am the CEO for Aetna Better Health of Illinois. That's our Medicaid plan in the state of Illinois. About 500,000 members that we have statewide. So when we think about our Medicaid population, a large portion of that is moms and children, and behavioral health is really something that's been prominent throughout that population. I mean, it's the #1 driver that we see in the state. It's the #1 driver we see across most of Medicaid. When we think about that population in the U.S., I mean, this is the population that needs the most help, the most support from an access perspective. From how do we simplify healthcare, right? This is that you think about health equity and some of the health-related social needs. I mean, it's paramount in this population. You can't have that group focus on health and access to health if they're focusing on how do they get a job, how do we think about housing, homelessness prevention, food insecurity. So I think we at Aetna today are very much thinking about all of those pieces coming together. We've touched a lot on holistic care, and that's foundational to the work that we do. And all of us, right? And I think as we think about innovation and we think about provider partnerships, payer partnerships, it's got to be how we link up and really synergize around that holistic care model and really deliver access in a simple way. I think I read a stat recently that 80% of the entire U.S. is unhappy with the healthcare experience through and through. And we've made things very complicated, we collectively as an organization and as an industry have. And I think it's a matter of how we continue to simplify that through and through. And for our youth especially, digital solutions, digital assets, I mean, that's going to be how we think about that innovation and partner up with our providers and work through some of those stigmas. But all of that cannot be done without the health equities and social, health-related social needs.
Thanks, Rushil. Hi, guys. I'm Jane Brown. I'm the CEO of Aetna Better Health of Kansas. I serve a very similar population to Rushil. Probably 70% of the members in my Medicaid plan are CHIP members, so pediatric kids, those under the age of 18. And I think, it's right. We are in a crisis. We have a mental health crisis in America today, and I think that's especially prevalent in our children coming out of the COVID pandemic. Isolation, school from home created a lot of challenges, and I think those are particularly evident in the Medicaid segment. So, my background is actually legal, and that's kind of how I ended up in managed care, is through regulation and understanding the regulatory landscape. And Medicaid, I'm here to say, in case you didn't know, is a very regulated space. And I think that regulation sometimes works against us. It's hard to breed innovation, it's hard to pilot things, it's hard to do new stuff that we think could make a change. So one of the reasons I'm so interested in Kooth and other digital solutions is to find applications for our population, but also to partner with our regulatory partners, our legislature, and other stakeholders within CMS, for example, that can help us sort of remove some of the red tape that is out there, so we can deliver solutions quicker, so we can try things. If they don't work, we get rid of them and try new things. But it has to be an environment of innovation, and it's up to us to create that environment. Please.
Good morning. My name is Erin Kaufer. I'm a state representative from Pennsylvania in my 10th year. I've served in a number of leadership roles in the legislature, including as the chair of our Drug and Alcohol Caucus, Mental Health Caucus, moved up through many leadership ranks, was honored by the National Conference of State Legislators as the Legislator of the Year for Mental Health a number of years ago by Mental Health America, and has continued to be involved in the mental health space, drug and alcohol space. I've been one of our policy leaders, and certainly in regard to drug and alcohol. Have had a number of issues that have been that I have led in bringing them forward through the legislative process, getting them signed into law. Recently had the mental health parity law, which was never adopted in Pennsylvania, just recently adopted and signed into law just a couple of years ago. I was a prime sponsor of that legislation, and have been working on issues related to mental health for a number of years. So often, and I'm a Republican, we hear so often when there is a school shooting or something like that, mental health, mental health, mental health. And so often it just gets talked about and nothing ever happens, right? It falls on deaf ears. Nobody takes any action. And as a more senior member of leadership after the Parkland shooting that happened in 2018, I said, well, who's actually going to address this? And I guess that means I volunteered for it, because it eventually became my policy initiative in Pennsylvania that led to Kooth eventually being adopted as one of the opportunities in Pennsylvania to be out there for students. We started a pilot program last year as part of our legislative process that took years to get to that point of working about how we're going to get out there to actually address this. And, you know, we as a legislature stepped up and said, we can't wait to figure out all the insurance coverages and the payer process and all of that. We actually stepped forward and said, we are going to take money directly from our general fund to make sure that we get this out to students now. We can't wait. We can't wait for another incident to happen in Pennsylvania or anywhere else where we talk about these big, broad, and lofty ideals, but never actually bring pen to paper and actually make solutions happen. So I'm proud of my time in the legislature and about bringing together these types of opportunities of public-private partnerships, how we make that happen, and actually, you know, being the force behind making those things happen.
Thank you. Representative Kaufer, I'll just start with you with the questions and just piggyback off of what you said. But during your time in the legislature, you know, as you just mentioned, you've been, you know, a champion for youth mental health and mental health overall. Given your involvement and your interest, can you just kind of describe how you personally see government policies evolving over the next few years in this space?
Yeah, and I think I sort of alluded to that a little bit. So, you know, one of the big things that I see us, especially at the state level, is trying to make sure that we get out there to engage with payers, right? What does that actually look like from a public-private partnership? And the people up here, you know, shaking their heads of how we work through these details, how we bring it together to make sure at the end of the day, we're doing justice for our citizens, for young people, and making sure they have the supports that they need and is so critical to their upbringing. And so, you know, a young person doesn't care about who's paying for it or the insurance coverage, but when they need help, they need to know how to access the help that they need. And, you know, that isn't through trying to figure out what insurance company provides it, you know, what parent's insurance it is, or is it Medicaid, or is it, you know, what program is it covering it? It's just to make sure that they know where to turn. What's the door that they need to open to and get to? So working through those issues of working through the payers, figuring out those types of issues, but is going to be key to these next steps of how do we make sure that these supports are out there. You know, just recently, you know, we had a big mental health hospital close in my area. You know, we worked quite diligently in my area to make sure that we found people to invest and come in there. You know, Geisinger has been one of them. You know, the Wyoming Valley Behavioral Health has been another one to come step forward, because it's not just that, but when people need help, they have to have a place to go to. And one of the pieces of legislation, drug and alcohol, I worked on was emergency detox and stabilization units. So often we're pushing people to our emergency rooms, where our emergency rooms are flooded and overcrowded and people don't know where to go. But we need to be able to stabilize people when they are at crisis. And we aren't doing a very good job of that right now. We're trying to put, you know, round pegs into square holes right now, where we need to make sure that they're getting the appropriate coverage that they need and the appropriate services that they need. And I just see it as there's so much more that we need to be doing. We spent so much time destigmatizing drug and alcohol over the last 10 years, and I've certainly been one of the leaders on that. But we need to spend that much more, that people are willing to talk and be open about the mental health struggles they're dealing with. It's certainly what I see over the next decade is destigmatizing those issues, but putting in place the appropriate supports and networks to support young people and others as we move forward.
Yeah, very good. And just a brief follow-up, since we're sort of focusing on this panel of the public-private partnerships, Representative, where and how does that private sector fit into your equation for expanding access and then also improving the outcomes?
Yeah, so one of the things that I've also been involved in, and I think of this is, we need to have those public players come to us. We don't know what we don't know as legislators, right? This is an area of pride of mine, of being involved in these issues, being knowledgeable on them. But most of my colleagues, this is not their area of interest. And I think Governor Inslee said it before when he was speaking of, go engage with your policymakers and take a chance to talk with them. Hopefully you guys know who your state representative is, or your state senator, or your congressman. Hopefully you know who they are. Hopefully they know who you are. Go and talk with them, because if you aren't engaging with them on the issues that you care about and that you're engaged on in the private sector, they can't help to address them. So one of the things that I see, especially at looking at the larger and broader brain capital initiative, I chaired our tax policy committee for too many years, of actually talking about how do we incentivize those initiatives coming forward. And a lot of the times that can be through tax policy, through tax credits, through those types of initiatives of creating partnerships of saying, if you're willing to spend your money here or there, we're willing to create that partnership and give that credit to you that we are truly partners in making this happen. And so, it's not just in the healthcare sphere, but it's in the broader sphere of what I think brain capital is here, of what we're trying to build here as an initiative. We need to be aggressive, not just on the mental health and on the coverage side, but also on what those credit models can actually lead to, not just on a state level, but on a national level as well.
Yeah, thank you. Norman, we'll turn to you now for a few questions, sticking with the theme of politicians. You have a very storied career.
Ex-politician.
What do you see as being the silver bullet in treating youth mental health, if there is one to be had, and where, if at all, do the private-public partnerships come into play there?
I don't think there is a single silver bullet. But there are some principles, I think, that we should stick to. And you're absolutely right. The voice of young people has to be at the heart of everything we do. We cannot presume to know what they need. And they should be able to offer their voice to the discussion. Secondly, we have to start from year zero or before. There are lots of evidence-based parenting programs, but we don't apply them. We have the evidence, we have the knowledge of what we can do, but we don't actually use them. We should be using them systematically wherever we are. Third, we have to ensure that given that by your early 20s, 75% of adult mental health has already emerged, these formative years through the teenage years are so significant, and yet we're failing to properly invest in that period of life. That's why I think the Californian initiative is so important to watch closely. We must surely invest in getting it right in those teenage years. And often we're talking about mental distress rather than mental disorder. And so it's not necessarily a medical response that we need. And that's why it has to be a combination between the public-private partnership that Kooth can offer to places like California and elsewhere. In the United Kingdom, most young people now, through contracts between Kooth and the National Health Service, now have access to support on their phones. And I think back to our son, when he was struggling with dark thoughts in his brain at the age of 13, 14, and felt unable to speak to anyone, including his parents, if he'd been able to go to his phone to explore what might be going on in his head, just imagine the relief that that could have given that young person. And dealing with that level of distress and anxiety as a teenager, on top of everything else you're dealing with as a young person, must be intolerable. And so we can provide help directly to individuals in that way.
Thank you.
Could I jump on something?
Absolutely.
So
To agree or disagree?
Oh, I can't disagree with a knight. So, yeah. No, completely agree. I think it makes me think of the, it's very easy to jump to the solution. So in my head, I'm a very visual person, which I'm really happy to be here in the Steelcase building. There's an amount of engagement we need to do with youth. There's a way to get them to the right services and navigate them through the mess of the payer system and what they qualify for and what they don't qualify for, and Medicare and Medicaid and whatever they have. And then there's an array of services that some, but not all, might need. But
Yeah,
you know, your child and others, the most important part that I think is missing in a lot of this is how do the youth get activated in the system in the first place? How do they start to develop the competence and the confidence to talk about their own mental health issues? And then from that ability, then how do they start to engage with the rest of the system? So we've been working at Optum and with partners at Healthline, who's here as well, on this concept of activate, educate, and engage, even before we get them into any kind of care navigation or get them to an app or a therapist or whatever. What's the investment we need to make to get youth to be comfortable talking about themselves on the platform or in the modality of their choice, which is TikTok? And how can they start to describe what they're feeling? How do they develop that language? And then how, in that second step, do they feel comfortable sharing that and developing that community to see how others are feeling well using a more sophisticated language and capabilities than they have right now? And for a lot of kids, that's all they need. For those that need more, now they're in a much better position to go get those services and get the help, engage with the system, and tie in to behavioral health resources that might be available from the state or from their hospital or from their school. But as we think about the process, go way back into making sure that those kids have the tools and the resources to talk about themselves. So this activate, educate, engage process, I think, really talks a little bit about what you were experiencing in your own family.
And if you don't mind, I'm going to jump from there too.
Yeah.
You know, that was some of the stuff we looked at in Pennsylvania too. Was we put actually out legislation to do an instructional study of what's actually being taught in regard to mental health, and then actually creating model curriculum of getting out into our schools that was created by our Department of Education to get kids talking about what these mental health issues are, to be able to identify them, and also be able to help teachers help identify them and do some instructional trainings for teachers as well. Because, you know, while I agree with you 1,000,000% that the kids are going to be on TikTok and going to be on those resources, but knocking down that first barrier, being able to start talking about it and being able to actually know what's going out, because it isn't a comfortable subject.
Right.
But to be there to start talking about that this exists, and you know, you're not the only one out there who might be dealing with this.
Yeah.
Being able
That's
to
the critical thing, because you feel you're alone. You feel it's only you as a teenager.
and getting out there to that broader educational perspective. In Pennsylvania, you know, that's what we've been looking to do and to expand in that way, so that those other accesses through the internet become more easily accessible, and that, you know, I'm not the only one to go out looking for it and to find it through those means that most people look for.
Yeah.
And then they're more likely to choose the modality that's best for them,
course.
because there's a lot of different ways to skin the cat on how to intervene with, you know, various types of interventions. They'll be able to drive a little bit of what is the optimal therapy for their situation.
Yeah, I want to kind of pivot and talk, you know, you guys have talked about this idea of an early intervention. Jane, you deal with the Medicaid population, and obviously that is one population that we see, you know, an increase in youth mental health issues and mental health issues overall. But what is your perspective on the idea of early intervention for youth mental health specifically? And how do you build a case for states to invest in youth and that upstream support?
Yeah, you know, I think we've spent quite a bit of time here talking about how do we navigate the payer landscape. We have Medicaid, we have private insurance, we have all of these, I guess, bureaucratic frameworks around how our children access care. And I think what we can do is, in order to kind of get at it earlier is think about tools and the tools that we can offer statewide. In other words, tools that aren't just payer specific, but tools that can be available just simply because you are a resident of the state of Kansas or a citizen of the United States of America. You should be able to access some sort of a digital platform for support. And I think that information could then go to your payer for additional interventions, for case management if there is a need for that, or whatever the case may be. But we don't think about things right now in our world holistically. We think about them in microcosmic little bite-sized pieces of what is a covered benefit, what is covered in my state today, what does the fee schedule say for that benefit. For example, we are looking to launch Kooth in both Kansas and Illinois. We think it's a great digital tool that can get our kids some access and support early. But how do we get that approved through our state? It is not a covered benefit. There's no fee schedule for a digital solution. We're going to have to get really creative in our private-public partnership and figure out braided funding solutions. We're going to have to invest, knowing that this isn't probably going to make its way through our rates, which is how Medicaid is built. So I think we're trying to forge a path forward, but on the back of a model that has long since stopped working. Yep. And so I think, to do that, I think it takes conversations like this. It's groups of people like the people in this room today talking about what is needed, what is the real savings here? What is the real cost of care? When we think about things in such a small, microscopic, tit-for-tat environment, we lose the big picture. And the reality is those youths who aren't getting those early interventions, I mean, they're in the ER. We have no beds for them. We have no places, no transitions of care. PRTFs in my state have a wait list. Kids have to get shipped out of state to other providers because we don't have access in the rural areas. So just the
And I guess, I don't know whether this is the same in the US, but in the UK, black kids don't use early intervention services to the same extent as others, and then they're overrepresented when it comes to crisis.
Health equity is one of the bigger, I think even through COVID, right, health equity became very much a buzzword in America. We think about it in more real terms by looking at our data, and you're absolutely right. It is black kids. They are not getting services. They are not getting to the doctor. And by the time we catch them, it's already too late because they're in the ER, and now we've spent thousands of dollars on a service that they didn't really need when we could have spent $10 on access to a platform, months before in the acceleration of a mental health crisis and prevented that from occurring. So this is why I think from a payer perspective, we're very much incentivized to figure this out, to figure out those partnerships. In my state, I work very closely with my legislators to educate about, all of the different options that are out there. What can we bring as a payer to the table? What I can't create from an Aetna perspective is uniformity across all payers. And that is going to take that bigger, higher level of thinking to really accelerate what our sort of mental health model is in America today. That's going to take almost federal level guidance, a uniform approach across our country, a definition of what is minimally required for every child. That has to exist.
Yeah, thank you. Dr. Berke, just kind of pivoting and following up on what Jane just commented on, what other barriers do you see out there that are preventing youth specifically from accessing mental health care?
Yeah, well, I think beyond what I talked about before, about that sort of self-ascension of being able to speak about it themselves and giving them sort of the tools and the license to be able to ask for and describe and demand. I think the concept of brain capital actually brings to mind all of the structural factors that go into that. You were alluding to as well around housing stability and food insecurity and financial stability. We take care of a lot of military and veteran families, and there's the care of the veteran, but what about the financial security, which then has an impact on the child, or them moving from base to base? What is the situation? How does that impact their mental health in that situation? So I think there are barriers that aren't necessarily in our sector of healthcare, but we always give a nod to, and it sort of calls the question about is brain capital, everybody's sector, or is it just an HHS thing? And I think it needs to be part of Department of Transportation,
Absolutely.
Education. If all of those sectors kind of have it as a mandate, or as you are deciding on a particular program or policy or an investment, how is this going to impact the health of a child? How is this going to impact the mental health of a child? It might change on the fringes a little bit to start some of our policy decisions, or change some of the rules and regulations about what we expect. All of those over time will have an impact on behavioral health. These aren't overnight fixes. We're not going to, get one app and one psychologist and solve all of the problems for the state of Minnesota. This is a longer-term play to build these other infrastructure pieces to handle it. But it's a multi-sector issue, and I think as long as it stays stuck in behavioral health, ain't going to work. As long as it stays stuck in medical care, the health
Totally right.
sector, it still isn't going to work. This has to be a multi-sector approach, and there have to be performance expectations of those sectors to come through and consider behavioral health.
It's an extraordinary thing that we spend so little attention, or pay so little attention, to the things that cause our mental ill health and our distress in the first place. We only focus on repairing the damage once it's done. And that's the shift, the fundamental shift we've got to make to help people become resilient as they grow up, and to enable them to enjoy happiness. It's that underrated pursuit of happiness that I think we need to be focusing much more on. What should governments be about ultimately, if it's not helping our communities to enjoy life and to have good lives and well-being? And let's just think a bit more about those things that trigger our unhappiness and our ill health in the first place.
Absolutely.
And I think, when you look at government incentives, right, there's a ton of government grants out there for all those different types of sectors you're talking about, whether it's our conservation, natural resources, Department of Transportation. You start listing out all those different departments within any state government, or even at a federal level. You start thinking about what it is to now move those up the ranks of what it is to more highly incentivize those types of initiatives, right, to build out more green spaces or those types of things to a better degree. I honestly believe the first state to really get their hands around this will see massive influx of private investment as well, not just public investment, but the private investment that's going to come along with it by trying to incentivize and take those steps forward as a state or a commonwealth in Pennsylvania's perspective, to make those types of investments happen, because it will breed further investment by the state taking it as a priority.
Yeah.
I completely agree with that. I think we are always looking for good partners, and I think that the concept of private-public partnership is one that really hasn't been fully unlocked. I think we have a lot of opportunities to think about, okay, this is the policy decision we want to set, but by setting that policy decision, this creates an environment for innovation for private investment. As a payer, we are worried about cost of care. It is rising. So how do we bend that cost of care while getting healthier people? And it is going to have to be sort of an all-system, all-hands-on-deck approach in order to really bend that cost curve in the long term. It's not going to be about cutting services. It's going to be about getting healthier people.
Yeah, and I think to that point, you got to remember healthcare is local, right? So I think what we deploy in California might look a little bit different in Kansas or Illinois. So I think part of the opportunity we have, whether it's private, whether it's payers, whether it's like our larger hospital systems, is we can try different things in different states, figure out what works, but we need conversations like this to go ahead and talk about where are those outcomes, how do we align on that, how are we adjusting it, and how do we take those best practices. So it's never one size fit all, but it's got to be that continuous iterative process that we have, I think, across the board to really help move the needle.
Yeah, sticking with you, Rushil. We've talked a lot about innovation and delivery of care, and the digital delivery of care is something that, has since COVID become, I guess, more commonplace. But how have governments been receptive to it? And what do you wish they knew that might alleviate their concerns about adopting this as one way of delivering care?
Yeah, I think 5 years ago when we would talk about, especially some of our Medicaid and Medicare population, the adoption for technology and just, whether it was just going on a website or looking at an AI bot or digital solutions, the adoption was very low. In COVID, we saw about a 12% increase in telehealth, right? And a lot of that was through digital solutions. A lot of our health plans today offer $25 to go ahead and purchase something at a CVS store. All of that takes place electronically. So over the last several years, we've continued to see the adoption, especially with our Medicaid population and our youth more so, adopting with technology, and we've deployed a few things in the market, especially on access to care for behavioral health. We have a group called My Own Doctor that really gets access to a lot of our children and allows them to access telepsych providers, telehealth providers. But part of that is how they're interacting with our population, right? There's an element of culturally sensitive care. We've touched on health and health equities, but how they're interacting with our Black and Latinx members and breaking through the stigma. It's a joint effort with our care coordination team, with the providers to kind of align on that front, right? I think the other thing from a technology perspective that we figured out, root cause, you think about behavioral health, loneliness has really been a driver in a lot of that. So we work with a group called Pix Health that really focuses on tackling loneliness early on, and we've seen some fantastic outcomes where you're seeing a decrease in your readmission rate, you're seeing less and less utilization in the ER, and that's not just a cost element from a payer perspective, right? The overall system and our providers, especially larger hospital systems in Chicago, for example, they see the value, right? Because then we're getting the right access to care, the right beds, the wait times are less. I mean, we're making an impact through the whole system end to end, and that very much aligns to those conversations. So you look at substance abuse, you look at some of the behavioral health conditions that we have, we're seeing loneliness as being a really big driver. There's a New York Times article, I think, a few months ago that came out on that, just stressing how that's really been one of the things we're focusing on, right? So, we're obviously excited to have Kooth come through. I mean, the school-based clinics and some of the things, how do we simplify care? How do we make it more accessible to our children is a foundational element. But I go back to I think what resonates with a lot of our policymakers as we craft that narrative is how does it tie back to the health-related social needs? How does it tie back to health, health equities? There's a lot of investments that we all make collectively, on housing, on workforce, on food insecurity, and if we can't do that while thinking about access to care and behavioral health, well, we're not going to see those outcomes that we're all looking for, right? So I think, again, running these pilots, and for us, it's a very localized approach. What works in the city of Chicago doesn't necessarily work in Southern Illinois or in Kansas, right? And we've got to continue to remember that healthcare is local. We've got to think about how we simplify it, tackle its health equities and needs. And what's interesting that we found in Illinois over the last several years is that creates a pathway for value-based care. Because now your providers are very much aligned with where the incentives are, quality and cost reductions, and how do we go ahead and collectively figure that out and work through that. And I think that resonates really well from our public partnerships and private partnerships to set that foundation.
Yeah.
Can I just comment too in terms of the expansion of telehealth? I think that because of COVID, right, we do see it. We see it in our coverage. We see it in almost every single state. Most Medicaid programs do now cover more telehealth services than ever. But, I would challenge all of us to look at payment parity. I mean, they might cover telehealth, but are you going to get paid as much for a telehealth appointment as you would for a physical in-person appointment? And that is a really important thing to think about, because it is those type of policy decisions and system decisions that will ultimately influence whether telehealth continues to grow and expand and get new applications, or whether it's going to remain chronically underfunded and providers are going to go in a different direction because they're not going to be able to get the investment that they really need to catapult it forward. So we have to think more than just, oh, great, we've expanded, telehealth, and to say, okay, and now what? And how do we keep growing it? And what are the other applications for it? And is it funded appropriately?
And also where it fits into the whole spectrum, right? That there's a role for telehealth that I think we're still figuring out where in that continuum of care does it fit in? Is it going to be more preventative? Is it going to be more on the, readmission side? And I think that's where we collectively, again, with provider partners, with CBOs, with payers, we've got to figure out what that solution looks like.
Yeah.
There's one other piece on public-private partnerships where I think there's a big opportunity, and it gets at this issue of we're going to saturate our workforce we already have saturated our workforce instantly, right? So what's the behavioral health workforce of the future for kids? And why are we stuck with the roles that we're stuck with? Doctor, MSW, whatever. It's a very guild-based industry, and we're very protective of our degrees, and the more letters you have after your name. But that also
reimbursement.
Right, it gets reimbursed. So, but it also creates a very precious resource then that's not scalable to a broader community or the state of California. So I think there's an opportunity to think about, new positions that might not exist now with new capabilities that are, they might not be a physician, but they can do an awful lot. We've seen, innovation in that over the years with dental technicians and physician assistants and other types of roles. Community mental health workers, peer support positions, if they can be trained in a robust, safe way. Registered apprenticeship models through U.S. Department of Labor have been used extensively in the United States and are now more and more being used in healthcare. The UK actually has a great community mental health worker model. I think if we don't start finding new types of people, in theory, well, it reads well in the paper, but if we don't start finding and creating those new roles for the future care delivery system, and if we stay stuck in the old model, we're going to end up with these exact same issues of oversaturation and inability to provide access in a timely manner.
And through Kooth, the ability to access a coach online, this is, we don't have someone called a coach in the UK, but it's maybe exactly what a young teenager needs to give them a bit of guidance and direction and reassurance and confidence and so forth.
Yeah.
Exactly.
We just have a couple minutes left, but we've spent a lot of time with this great panel talking about the challenges. So I'd like to start with you, Norman. And if you could just briefly tell me one thing that you're optimistic about in tackling this challenge that's before us.
Well, I'm optimistic because I think we have reached a burning platform. We've heard so many times this morning about how the traditional system is completely failing. And that means children in particular are at massive risk, and there are lifetime consequences. I often think that we talk only about their health, but what about their education? When a child's waiting a year for treatment, their education is suffering as well. So my confidence comes from the fact that the system is failing, and it is imperative that we change it and that we change it now. And we have the means to do it. This is the exciting thing. There are opportunities, and California, I think, is leading the way in making an investment, embracing private-public partnership, and going for it. And we have to grasp this moment.
Same question, Dr. Berke.
You took my answer, but
Sorry.
No. But the other thing that makes me optimistic and where I have confidence is in the kids. And I think they have a voice that has not been present in prior generations. I think they have an expectation. I think they're much more comfortable talking about these issues. I think they have a long way to go. But they have an expectation that we are going to deliver something different that actually meets their needs. And now it's our job to hear from them about what to deliver. But the confidence is that at least we have someone to guide us, and we just have to look at those other generations.
They're suffering
Thank you.
in this process. They are getting it, but they're also suffering.
They are.
Yeah.
I'm talking on behalf of my own group.
Yeah.
No, you're absolutely right.
Yeah, Rushil?
Yeah, I think with COVID especially, right, there's just been a jump and an acceleration over the last several years, and there's still a lot of work to do, right? So I think if you think about how quickly we've accelerated over just sort of the last 3-4 years, I mean, I think there's definitely some optimism there. But again, I think it's an appreciation for it's not a one-size-fits-all. It's going to be a custom approach. It's going to be continuously iterating, looking at it at a local level. And I think that's foundational, right? We always talk about how the member is the center of what we do, and that has to continue through. So I think as we deploy new things across the board here and try new things, we're going to have to continue to assess what's working and what's not. So I think overall, we've got the right people in the right room and the right conversations happening, and I think that's fantastic.
I think it's sad that it takes a global pandemic to evolve our healthcare system, but that is where we find ourselves. And so I'm optimistic that we have learned some lessons here. I do see regulations evolving quickly. I see the rules of the road at the state-based level changing. I see legislators more involved than ever before. And so all of that kind of gives me hope that we can get to a framework that is smart, that does work, that is more nimble. And I think the other component is actually something Dr. Berke said. I think I am probably the millennial in the room, along with maybe Rushil. And you're right, we're probably not going to get it right, but I think we're going to get it more right than previous generations. And I think that we are willing to work with Gen Z and really anybody else up and down the age spectrum, but we do bring a unique focus, which is we are comfortable with technology. We've grown up with it. I guess we take it for granted, but a lot of the solutions that I think about when I have a problem is the digital solutions. That's kind of where I go to first. So I'm hopeful that with the pandemic, the regulatory changes that have ensued, and with just our approach to technology as a generation, that we can make a change together.
And just launching off your point of the global pandemic, forcing there to be some resolutions to these issues, I think a lot of what we're seeing is even more and more focus on young people coming out of this. And so, we see solutions like Kooth that have come forward and others, but really trying to address the issues through that school-based setting and really trying to get more focus on kids on where they're at. We already know they're going to be at schools. Where can we provide those right supports to help knock down some of these barriers and make sure that they're getting the help and supports they need? The school setting, I think, is one of those settings that you can be out there to help kids in so many ways, whether, not just through healthcare, but also through food insecurity and other issues that I've seen in my community that has really grown towards trying to address those issues of having after-school programs focused around the school so that kids have somewhere to have a supportive network, big brothers, big sisters, those types of programs that I've seen in northeastern Pennsylvania grow since the pandemic has happened. There's so much more focus on wanting to support our young people, and I think in an era where we are so politically divided and so politically partisan and at each other's throats, that it's going to shine through making sure that we're out there supporting kids. I really think that focus and being policy oriented and wanting to help people is what's going to win the day.
Thank you. What a great way to end. Thank you, panelists, for just your time and your commitment to this.